All right. Good morning, everybody. I'm going to talk a little bit about how to fix pelvis fractures, which compared to the last two talks is relatively simple, it would seem. So the fundamentals of fixing any pelvis, dysmorphic or not, are sort of listed here, I think. So number one, the thing has to be reduced. In general, I think of these procedures as a way to fix the bone, not a reduction technique, although there are some exceptions with widened SI joints. The meat of this is understanding the normal and the dysmorphic sacrum. And then you need to understand how to interpret fluoroscopy. There are people, including someone right in front of me here, who will do this with navigation at least sometimes. But even in those cases, you still need to know how to use fluoroscopy to do this safely. And then like anything we do, you got to preoperatively plan, and I'll show you at least how I do that. So there's two types of sacrums out there. There's the normal and the dysmorphic, and both of them are common. The normal is maybe slightly more common, maybe 60% or so. And this was originally described on an outlet view, and some of the things that were described to help you identify this are listed there, most of which, in my opinion, are frankly unimportant. So the way this was described is that the top of the sacrum is below the top of the pelvis. There's no disc between S1 and S2. The foramina look round. There's some other things on the list here that I didn't put there. But essentially, what a normal sacrum has is the S1 body exists between the posterior ilium on each side, such that there is a transsacral corridor. And I'll make this more clear on a coming slide. But if you look at this pelvis and then can compare it to this guy, there are some important differences, or there's one important difference, and there's a bunch of trivial differences in my opinion. So again, this is an outlet view, obviously stolen from chip route, and if you look at S1 here, the top of that sacrum is closer to the top of the ilium on the outlet view. There is a residual disc there. The foramina are less round. There's some mammillary processes, which are those little ears on either side of the sacrum. Again, none of that's really that important. What's important is the position of the sacrum has been moved forward and up. And so now the S1 body doesn't have bone next to it on each side, or the ala don't have bone next to it on each side. There's a gap. And again, I think this is more easily seen on a axial CT. So when I define something as either dysmorphic or non-dysmorphic, this is actually primarily how I define it. Do I think there's a transsacral corridor that I can use that is safe? We have the same models, the 3D models that we were using before, and now we have an axial slice through the same type of pelvis below it. And you can see in the S1 corridor, you can draw a straight line across S1 in both posterior ilium. If you try to do that same exercise at the level of S1 on a dysmorphic sacrum, you will never find a safe corridor for a screw. You're either going to go through the foramina or you're going to go through the L5 nerve root and be outside, sort of in, out, in, as it were. So that's the key difference between these two types of sacrum and pelvis. Doesn't mean you can't put a screw in S1. In fact, you can do this regularly, but that screw is going to be sort of an iliosacral style screw that is aimed forward and up. Importantly, all types of sacrums have S2s, and there is a transsacral corridor in both types of sacrums. So all we've done is take an axial cut that's one level down, and now there's room in both of these sacrum to go all the way across. And actually, interestingly, the S2 corridor in dysmorphic sacrum is often a little bigger and a little safer than it is in a normal sacrum. So now we know our anatomy, we know which pelvises have what sort of corridors, but you also have to know how to interpret fluoroscopy in order how to do this safely. So you have to take the axial CT scan and apply that to intraoperative fluoroscopy. So again, same pelvises, same axial CT scans, and now we've got an inlet view of the sacrum. And this has been taken such that the S1 and S2 bodies are overlapped at the front. And you can see there's some white arrows and some yellow arrows, the tips of which are pointing to some densities, some lines. And in both cases, the white arrow is trying to show you the more posterior S1 ala, and then the yellow arrows are pointing to the more anterior S2 ala. So you can see in both of these guys, you have an S1 and an S2. The S1 is more posterior than S2. So you just need to know which one is which when you're instrumenting each level. All right. So if you place a green screw behind both of these lines on the left-hand side there, your postoperative CT scan is going to look like what I've shown here. If you do the same thing at the level of S1, but misinterpret which line is which, and you think that more anterior line is your S1 and don't realize it's the scalloped line, you're going to put something in there that looks very similar to the other side and actually looks safe in some ways. It looks like you're behind a posterior line. But you're behind S2 and you're instrumenting S1. And so what's actually happening on your postoperative CT is what I have demonstrated there on the axial view. You're going to be in, out, in, and you're going to pick off L5 nerve roots. So interpreting fluoroscopy is very important. Here, all I've done is change the color of the line. That's how I made this very sophisticated slide. I changed the color of the line, and then I changed the picture from S1 to S2. So the screw looks identical on your inlet view. It's just that now you're instrumenting the S2 level, and so you can be in front of that scalloped S1 line, but you still, of course, need to be posterior to the S2 line. Okay. The other thing that I didn't understand for a while was this thing called the iliac cortical density, which I used to think was like some sort of magic line. Turns out it's just a piece of bone. So the iliac cortical density is just the bone of the ilium that is just lateral to the sacrum on each side, and it just turns out to be pretty white and dense, so you can see it on your lateral sacral view. If you are placing a screw that's transsacral in a non-dysmorphic sacrum, a normal sacrum, you can see you should never be in front of that line. However, if you are placing a screw into a dysmorphic sacrum, you are definitely going to be in front of that line at some point, and so that's fine. You just have to be in front of it at the right time. A couple other minor things. Generally, when we're applying fixation for a SI injury, we're going to do it perpendicular to that structure, which is aiming a little forward and a little up. And then for sacral fractures to get the compression that Dr. Alnaga was just talking about, sometimes we might apply that in a more perpendicular fashion. All right, so now let's do some pre-op planning, which is the last thing I'm going to try to get through. We've got the same pelvis with two theoretical injuries, one with a SI joint injury and the other one with a sacral fracture. And so the first thing I do is I draw out the corridor that I want. So up there at the top image, I've decided I'm going to do a iliosacral style screw that's going to aim up and from posterior to anterior. So I draw that corridor out, and then I can measure the length of the screw, and this tends to be pretty accurate, within about 5 millimeters. And then you can measure the size of your corridor, and then if you had your sacral injury, you can do the exact same thing, but just draw out a transsacral corridor instead. The other thing that I find very helpful is to do this, which is on my sagittal view of my CT scan, in the mid-sagittal view, measure out what the inlet and the outlet angle is going to be. So just picture, how your CT scan is going to have to tilt relative to a straight up and down A to P shot, which is the longer line. So you can get some ballpark of what this angle is going to be. And this is not perfect, but it's usually within 5 or 10 degrees. And there are some people who have extremely small inlet angles, and some people who have quite large inlet angles. And I think that's the one that's hard to interpret. So having some ballpark of what you're aiming for, I think is helpful. The other thing I've started to look at is how curved that S1, S2 body is. So you can see this is a patient that actually has a bit of a curve there. There are some people that are very straight. And so in the people with the very straight front of S1 and S2, you will get those two bodies to line up perfectly. And in this person, that's not going to be the case. You can still get them to overlap somewhat, but there's going to be a series of tangents here where they will overlap. And so there's a little bit of play there. Okay, this is a young lady I took care of a while ago. She's got a LC2 type injury that goes through her SI joint and her posterior ilium, so I decided to treat her with some screws in the back. So this is me preoperative planning. This is her S1 level. So again, I draw out my corridor that's going to be kind of perpendicular to the injury. I measure the size of that in terms of width and the length of that. And then I'll do the same thing with my S2 corridor. measuring its size and length. I decided not to go all the way across because she's young, and I think I can spare her the contralateral SI joint disruption. And then I measure her angle. All right, now I've got my, my inlet view, and I have had this set up the same way that I had the other images set up earlier, where S1 is more posterior than S2 with those sacroiliac bodies overlapped in the front. I put a K-wire through the skin, and all I'm trying to do here is get the start site. So I'm trying to get a start site that I can aim up and from P to A into the S1 body. So my trajectory here is not great, but my start site's good. And then I'll make an incision and swallow that wire, and now I've got a big stiff 5/0 drill that I can steer a lot better than a K-wire. And I will get that along my trajectory up just across the SI joints, at which point I'll switch it out for a safe wire that's backwards that will hopefully navigate in between corridors of bone. You can see I've stopped the wire just lateral to the foramina, and so now I'm going to check this image because even in a dysmorphic sacrum at this point, you shouldn't be across the iliac cortical density. And then this is a football of safe bone if you're doing a transverse screw. I'm not doing a transverse screw, but if I was, I would want my wire to be aiming into that. Now I just put this thing in a little bit deeper and apply a screw and do the same exercise at the level of S2, and then here's her final sacrolateral where the tip of that S1 screws anterior to the iliac cortical density. All right, whirlwind through the pelvis. Thanks very much.